I know many of you know Dr. Smith pretty well. For those of you who do not, he's the chief of GI and hepatology at our hospitals, and you might frequently see him in the GI consult service or work with him while you're rotating there. So thanks again for being here, Dr. Smith.
My pleasure. It's great to see everybody. I really enjoy these when they're, you guys are in 3 dimensions instead of little boxes on my computer screen. So I'm kind of hoping that we've reached the end of this, and the next time I give this lecture or similar lecture, it'll be in that context. And I know I often give a talk on dysphagia, and maybe you guys will be nice enough to invite me back to do that once we're in person. But this is an important talk for a number of different reasons, and I'm going to get into some fun stuff that we'll talk about sort of the cutting edge of how we manage reflux disease and its complications, including Barrett's. But my hope is to really focus you on the key takeaways related to management of this condition and diseases related to this condition that'll come up in the same differential diagnosis. So that as internists, and no matter what subspecialty field you go into, if you go in that direction, there are going to be takeaways that your reflux isn't just referred to reflux is not just referred to GI for reflux, right? That you can manage some of this on your own and you're thinking about it. And not everybody's going to become an esophagologist like man, who'll be reading all your manometries and your pH studies for you in a few years. And you'll be calling them up in whatever hour and saying, what can I do? But my hope is you'll gain a little bit of more independence on this, because quite frankly, 30% or so of the American population probably has clinically significant reflux disease. And so, chances are no matter what field you're in, you're going to have somebody with this and or a family member who will bug you incessantly whenever there's a news story or an article about something and ask you for your opinion on what they should do to manage their condition. So I hope in that context that I can provide a little bit of a benefit and maybe some entertainment as we go through the next 50 minutes or so. So let's get started. Learning objectives, again, understanding what facilitates the development of gastroesophageal reflux disease or GERD, what the typical and atypical symptoms are in the presentation of the disease, what are the tests out there that we can use to diagnose and assess GERD and look for its complications, talk about the available treatments for GERD, which are probably greater than you're all thinking of, and what you've probably seen in the clinics that you've been attending. And, most importantly at the end here, characterize the potential complications of GERD and why it's important to treat it and to stay on top of it in a preventive kind of way so that people don't have to deal with the ramifications of uncontrolled disease. So before we get into the issue of GERD, why don't we focus on the question of esophagitis? A lot of times people will come up, and the first thing you'll think whenever you hear that there's esophagitis on an endoscopy report or on an esophagram of some kind, people, the differential diagnosis is reflux, 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 reflux. There are a lot of things out there that can cause irritation in the esophagus, inflammation. And so before we go into really focusing on GERD, I just want to remind you of this. It's a common question on the boards for internal medicine, but it's also something that I think is helpful because, taking a good history and really thinking about this can help speed up your evaluation process and get to the right answer and provide symptomatic relief for the patient. Because when somebody has really significant esophagitis going on, it's greatly disruptive to their quality of life, as well as their ability to have basic functions like, eating, right, and drinking. So lots of things to think about here. Yes, obviously reflux of gastric contents and sometimes duodenal contents retrograde into the esophagus can certainly cause irritation, but so can other conditions like an allergic condition like eosinophilic esophagitis, where food allergies actually generate an eosinophilic response on the wall of the esophagus, affecting the distensibility of the esophageal wall, the ability to eat. And children, that manifests a lot of times as failure to thrive, and adults in dysphagia, and actually even food impactions. We could see that a lot. So you may have called us for that at late night and very odd hours, because that's inevitably when those patients present to us. But there are other things as well: infections, viral, fungal, and bacterial, that we have to think about. Patients who've had interventions, particularly for cancer, either chemotherapy, radiotherapy, or combination chemoradiotherapy, very often we'll get radiation esophagitis, and it's not just for esophageal cancer. Breast cancer, mediastinal tumors that get treated, lymph nodes in the chest that get treated, and there's overlap with the esophageal space. As good as we are at focusing in the treatments now to really hit just the target organs, the esophagus is often an innocent bystander, and we have to think about that for patients who develop discomfort, dysphagia, chest pain in the setting of that treatment. We have to think about toxic exposures, pill esophagitis being the classic one that you really want to think about. Lots of those possible meds that are listed. Graft versus host disease in patients who've had stem cell transplants, not at all an uncommon thing to be looking for and to be thinking about in those folks. And then thinking about underlying conditions that affect the protective mechanisms of the esophagus to prevent reflux and exposure, like hypothyroidism, scleroderma, and pregnancy that can affect the integrity of the lower esophageal sphincter and its function, or diseases that affect the mucosal barrier to inflammation, such as pemphigus, pemphigoid, and epidermolysis bullosa. And then, unfortunately, in the setting of traumatic exposures, again, food ingestions, foreign body ingestions, but also intubation that goes wrong, where it's not the trachea that gets intubated, but the esophagus, or it's maybe intentionally the esophagus, but with a probe like a TEE probe. So all you budding cardiologists out there, don't forget about the fact that you can really cause some discomfort and irritation and even perforation of the esophagus with that TEE probe when it's going in. So again, don't just think about reflux, think about this wide spectrum of disease that can cause inflammation in the esophagus. But let's focus in on the talk. This is a talk on reflux, right? So let's talk about the Montreal definition of gastroesophageal reflux disease. There are several out there, but this one has gained a lot of traction. It has its shortcomings, but it gives us a sense to really understand how patients will present to you in the primary care and internal medicine sphere. And that's a definition of GERD as symptoms and or tissue damage secondary to the reflux of normal gastric contents. So a couple really important things here. First of all, it doesn't require you to have reflux esophagitis, Barrett's esophagus, a stricture, an ulcer in the esophagus. What you need to have are symptoms and or tissue damage, meaning that if you're getting a response, the patient's having an uncomfortable response due to the reflux of those contents from the stomach back into the esophagus, that qualifies under the Montreal definition as GERD, or gastroesophageal reflux disease. Everybody gets gastroesophageal reflux. It's normal because the lower esophageal sphincter has to open up from time to time. Otherwise, you get a tetany-like situation that it has to take a break. If it takes breaks at the wrong time, or it takes breaks too many times, that's where we can see the development of a pathologic exposure to the refluxate. Or in the setting of perhaps reflux hypersensitivity, you've got a normal amount of reflux, but a sensitivity of that esophagus to the reflux that's leading to the damage, or leading to the symptoms, or leading to both. So how do you get GERD? What happens? Well, there's lots of things that can go wrong, and in sort of combinatorial fashion increase your risk of developing gastroesophageal reflux disease beyond the normal amount of reflux that you can have. Right? We talked about some of these before on that initial differential for causes of esophagitis. If you lose the protective barrier of the esophagus, you've got less saliva in there, you've got poor peristalsis to push the refluxate back into the stomach. If you've lost gravity, for example, a post-operative, a comatose patient, right? Think about your ICU folks who are intubated, sedated, and lying flat forever. There's no gravitational barrier to reflux that's going to pull that fluid back down into the stomach. If you've got decreased mucosal resistance due to reduced secretion from the submucosal glands, that LES dysfunction we've talked about before, but even gastric causes. This can be a plumbing problem. If the stomach is slow to empty, if the lower part of the GI tract is not moving things forward appropriately and there's back pressure, those contents from the stomach will push back because they have nowhere else to go, and that can cause the symptoms and or tissue damage that qualify as GERD, right? So think about those pieces as you're putting this all together, and remember that any downstream backup can certainly make its way back into the esophagus and cause the problems. And what are the pathogenic factors in actually causing reflux esophagitis? Well, there are several that are known out there. How much fluid comes back? how long it's in the esophagus, what it's consisting of and how caustic that stuff is, how easily the reflux event is cleared by the esophagus after it occurs, and are there any anatomic variants that are predisposing you to either getting more reflux or not clearing out as well, like a hiatal hernia, and we'll talk about that more in a second here. So this is our normal gastroesophageal junction anatomy, right? We call the area inside the red oval the esophagogastric junction high pressure zone, because you see that the diaphragm, which is running across east to west, is lining up with some bulkiness here that's described in the esophagus, which is the lower esophageal sphincter. And that combination of the two muscular structures working in combination and in synergy is what allows the esophagus to provide an effective barrier to refluxate when even when the lower esophageal sphincter takes a break. You'll also notice, and this is really important, we try to show this to the fellows when we're doing endoscopy, that the esophageal lumen empties into the stomach, not in a perpendicular orientation, but you see how it comes in at an angulation. That angulation is called the angle of His, H-I-S, like the His bundle. And that angle of His allows you to have more of a one-way flap valve that closes up on itself rather than a perpendicular valve that may be more open to having backflow from the refluxate. So that combination of the diaphragm and the LES sort of in continuity in a craniocaudal orientation, and this one-way angle of His directed gastroesophageal flap valve really do a great job of preventing reflux in the vast majority of patients. However, here's where you have a hiatal hernia, and you see that the top of the stomach works its way through some laxity in the diaphragm. And so the top of the stomach is above the diaphragm now, separating the diaphragm from the lower esophageal sphincter and leaving this pocket, what we call the acid pocket, the acid reservoir, or the refluxate reservoir, in the top of the stomach, but that only now needs to traverse the lower sphincter in order to get into the esophagus and start causing damage and irritation, right? And so losing the alignment of the LES and the diaphragm in the setting of the hernia is the reason why the hiatal hernia really predisposes you to getting reflux. Now, add that to some other things like dysmotility of the esophagus or taking a medicine that relaxes the lower esophageal sphincter, having a state like pregnancy where you've got increased intra-abdominal pressure as well as progesterone decreasing LES tonicity. Now you've really set the patient up for having a lot of reflux. So you can see how all these pieces combine together for increasing the likelihood that someone will present to your office or call you up and say that they're having a lot of heartburn. Now, remember that the majority of patients who have GERD don't actually seek medical attention. I call this the Gerd Iceberg because if you think about it, there's a very little percent of the iceberg that's actually above the water, and most of it's below the surface and not seen, which is exactly what happens. Patients are self-treating. They're getting Larry the cable guy to tell them they need Prilosec OTC, and they're going to the pharmacy or they're going to the store and they're picking up some of that over-the-counter H2 blocker or PPI, and they're taking it, and they're doing okay because they just have mild recurrent symptoms, and it just doesn't rise to the level of seeking medical attention. Then you've got the area between the two yellow bands, which are the area that you will see in your primary care clinic, right? Where there are frequent enough symptoms, it's bothersome enough that they want to do something about it. And that whatever they tried at home, their home remedies, what Dr. Google told them to do, isn't working completely. And so they're coming to you in the primary care office, but really only the tip of the iceberg are getting to us in the gastroenterology community because there are patients who have chronic symptoms and complications, or you've got that small little tip on the far left of the folks who freak out, hear that they're going to get cancer and die from their reflux, and they immediately make an appointment with 4 different gastroenterologists to figure out how they can't die, right? And that's a small group, but unfortunately in the era of the internet becoming a little bit more common. So we're really going to talk about that group in the middle band there where you're seeing who have frequent enough symptoms that aren't fully relieved with their home remedies or their OTC treatment and are seeking attention for it as well. So the classic symptom of GERD is heartburn. And remember that what a patient thinks is heartburn is not what we would define heartburn as. We in the medical community define it as retrosternal or substernal burning and or accompanied by regurgitation, or a feeling that contents of the stomach are moving up retrograde behind the breastbone up into the chest. This is generally postprandial. It's aggravated by a change in position. So they'll tell you if they bend over to pick something up, they'll feel things kind of work their way back up, and then they can get that burning, and it's promptly relieved by antacids. You'd be amazed at the number of patients who walk into my office who tell me that they have heartburn right here in their throat, right? Or heartburn down in their belly, clearly below the rib cage and below the breastbone, right near the umbilicus, and they're telling you that they have terrible heartburn. Well, that's not heartburn, that's dyspepsia, as we all know, and that's very different. And the advice I will give you is when somebody tells you that they have heartburn, ask them very clearly, what do they mean, and have them point to you where it's located. Because if you get things down in the abdomen, this isn't GERD, right? Gastroesophageal reflux disease means that the reflux has to hit the esophagus. And if it's not getting to the chest and not causing symptoms there, it's not a gastroesophageal reflux. It's probably dyspepsia, and most likely functional dyspepsia, as a result of irritation from acid, bile, other digestive juices sitting in the stomach. All right, so my advice here as an internist is please make sure that you ask exactly what they mean when they tell you they have heartburn or they tell you you have burning. Don't just assume that it's retrosternal. But also remember, there are a lot of other symptoms that can cause, that can be emblematic of GERD, even though they're not typical. They're not the typical heartburn and regurgitation. Lots of referrals from the ENT colleagues for hoarseness, chronic cough, globus sensation, bad smelling breath. The dentist will refer for loss of dental enamel, especially on the back side of teeth, where you wouldn't expect to see it in someone who's having too much sugar intake and not brushing well. Our pulmonary colleagues will send for asthma and respiratory diseases that aren't coming back with positive testing for asthma, for example. Or our lung transplant program often refers folks with pulmonary fibrosis who end up having silent reflux that's been severe enough to scar their lungs from the inside out and generate enough scarring in the lungs that they now need to be considered for transplantation. And of course, our friends in cardiology will refer patients who had chest pain that's been worked up with now has a negative stress, a negative echo, sometimes a negative cath, and they're still having chest pain, excuse me, and sending those patients to us for an evaluation for GERD. Okay, what do we see in the patients who actually develop reflux esophagitis, which is only really present in about a quarter to a third of patients who have GERD? And you can see here a list of all of the histologic changes going from the least severe on the top to the most severe on the bottom. And it's really important to remember that just because you send someone for evaluation of GERD and they get an endoscopy, or they come to you as a new patient with an endoscopy report for reflux and you don't see esophagitis, that does not mean the patient doesn't have GERD. In fact, that means they're in the potentially in the majority of patients who do have clinically significant reflux disease. They just don't have an erosive esophagitis component to it that would come up with some of the more severe findings that you could see on this slide. All right, how do we evaluate the GERD? Lots of different tests out there that we can use, and I would just say at a high level, we're evaluating based on how the patient describes their symptoms to us. If a patient comes in, for example, saying that they have dysphagia, a barium esophagram, which is the one that you see here that really focuses on esophageal imaging, as opposed to a modified barium swallow, the modified swallow being one that focuses more on oropharyngeal dysphagia and the hypopharynx and clearance into the top part of the esophagus. The barium esophagram does a really nice job of looking at sort of a poor man's version of the propulsion through the esophagus, the peristalsis, but also looking for anatomic abnormalities like the peptic stricture you can see in the bottom right of that image there, sitting above a small hiatal hernia that looks like the little mushroom above the diaphragm, and you can see the rugal folds of the stomach in the bottom right corner. So this is really great for looking sort of at a gross set of motility and structural based abnormalities, but it doesn't quantify at all what's going on with reflux. And it also doesn't tell you whether or not there's a sufficient amount of reflux taking place to explain the patient's symptoms. We can also use endoscopy, and as I mentioned before, endoscopy is great at looking for complications of GERD, like reflux esophagitis, Barrett's esophagus, hiatal hernia, strictures, and it allows you to take tissue biopsies to look for those changes I showed you on the recent slide. However, it's very expensive. It often requires the patient to undergo anesthesia, right? There's certainly that higher cost to it, and if the patient has copays, that makes it a lot more expensive. And again, if about 2/3 to 3/4 of patients with clinically significant reflux don't have any findings on endoscopy, making a confirmation of a diagnosis of GERD with endoscopy is going to miss an awful lot of stuff. So it's not a very sensitive test for GERD, but if you do see reflux esophagitis or Barrett's, you can feel pretty comfortable in making it. So the specificity is great, the sensitivity not so good. We can also do some quantitative reflux testing. We have the ability to place a transnasal catheter that has sensors in it to measure whether or not someone is having reflux, what the pH of that reflux is, and at multiple sites in the esophagus, how high that reflux gets. That's a 24-hour pH impedance test, as you see on the left side of the screen. And on the right side of the screen, endoscopically, we can place a small wireless probe. Dr. Shenoy was placing a few of these with me in the last week or so in her rotation. And that allows you to quantify using a radio transmitter to collect the pH data, how much acid exposure there is to the distal esophagus, where this is placed about 5 centimeters above the lower esophageal sphincter. You can see the patient's much happier. They don't have something sticking out of their nose. And you do get a 48-hour, up to even a 96-hour test now with this. You get an additional amount of data, but you only get to look for acid reflux. So patients who are on PPI medication or H2 blockers would have to stop them for a week to do the wireless testing. And it only tells you whether or not you have the reflux, not whether or not that reflux is controllable. You'd have to use the catheter test for that. So those are really good tests to quantify the amount of reflux. We can also use something called esophageal manometry, which we'll talk about more in the dysphagia lecture, that really tells you how the esophagus is doing from a strength and coordination of swallows standpoint, as well as a strength of the muscle tone in the sphincters standpoint. You get all of that data as it goes, but it is something that is done awake and transnasally. So even though you numb the patient's nose and throat, they're not necessarily thrilled that you're shoving a catheter down their nose while they're awake. And it is a little bit unpleasant. I've had it done to myself to see what I was putting my patients through. But it also doesn't quantify how much reflux you're having. It just gives you a sense of how the muscle function may be predisposing you to reflux. So you see how this test is helpful for somebody who says, I'm having trouble swallowing, feeling like things are getting stuck, or someone where you're assessing before you're going to make an intervention, what is the underlying protoplasm of the esophagus, how good a swallow do they have, and what options for managing reflux might be on the table. But in terms of diagnosing GERD, a very limited benefit. And here you can sort of see in table form those different opportunities that we have. And in particular, if we want to quantitate reflux, if we want to make a diagnosis, and if we think the patient is having atypical symptoms that we want to either link to reflux or exclude reflux as a potential cause, doing that quantitative testing, the ambulatory pH monitoring, is really the gold standard for where we want to be focusing our time and our efforts. So once we've made the diagnosis of GERD, what are we going to do about it? Well, there are really 4 goals that we want to think about. The first is we want to eliminate the symptoms. The patient is most likely coming to you because they don't like how they feel in the setting of the reflux. So if we can make those symptoms better, make them happier, that's a win. We also want to heal the esophagitis before that scars down and forms a stricture, or it progresses to form Barrett's esophagus, or you could even get a deep ulceration that could risk perforation, right? So healing that esophagitis and getting the esophagus back to normal tissue is also a win. Managing or preventing complications, as I mentioned before, super important. We don't want this reflux to cause damage to the esophagus, to the throat, even to the lungs later on. And we want to be able to maintain remission. So no matter what treatment we give, we want the patient not to have to come back every month and tell us that they're having the same problem. We want them to get out of symptoms. We want them to be asymptomatic and stay that way. So we've got a lot of medical options for GERD treatment that we can consider. Everything from dietary and lifestyle modification through topical therapy, prokinetics. We can use medicines to try and improve the strength of the swallows. And then, of course, we could use medications to try and blunt the amount of acid that's being made in the stomach that can then be refluxed back up to cause that irritation of the esophagus. Now, the guidelines I'm going to quote from now are the 2013 guidelines from the American College of Gastroenterology. They've recently been updated, but they did such a good job going through this and reviewing the data, and that part hasn't changed, that I've left these in here. So they give you a good sense of things. Weight loss is a great way from a dietary and lifestyle modification standpoint to control reflux. And in fact, a lot of your patients will probably tell you that if they've put weight on, especially their COVID-19, they are feeling more reflux than they used to. And that if they lose even 10, 15 pounds, that they get a significant improvement in their reflux as a result of that lifestyle modification. So completely recommended. Weight loss is a great thing. Of course, hard to achieve, but something that has been shown to be helpful for these folks. Head of bed elevation for patients who have nocturnal reflux symptoms, or what we think is nocturnal damage from reflux, works very well. And again, I recommend that in all of my patients, even the ones who don't have tremendous quantitative evidence of nocturnal reflux. It is something that I recommend to try and get their head up to about a 30-degree angle, if at all possible. And multiple pillows are okay. A wedge pillow that's a little bit more firm or an adjustable bed works even better. And as much as I would love to be able to tell you that there are certain foods that predispose you to reflux, in particular chocolate, caffeine, alcohol, which are thought to relax the lower esophageal sphincter, acidic or spicy foods. We always tell people try to avoid those spicy foods. Not recommended in the treatment of reflux disease. The data, unfortunately, just isn't there. That being said, do we all still tell them to do it? Yeah, of course we do. And in some patients, it does help. But unfortunately, the data aren't there. And as much as we want to tell people to stop drinking and smoking, those have not been shown to change GERD symptoms or esophageal pH results on quantitative testing. So you just got to be careful about it and recognize that that is not the absolute fix. But in the setting of doing other things, and again, this is a multifactorial etiology to this disease, this could certainly help and be part of a successful solution. Hold on one second. I'm having a little delay here. Oop, there we go. All right, let's talk a little bit about prokinetics. Some folks will come to you, especially from outside docs who've been practicing for a long time, not just on an acid blocking medication, but a medicine like Reglan or metoclopramide to speed up their stomach. And the thinking is, if your stomach is empty faster, there's nothing to turn backwards and get refluxed into the stomach. In particular, Reglan is one that often has been looked at, though the data suggests that this is not helpful in anybody who doesn't have delayed gastric emptying. And as many of you may know, this medication has a black box warning from the FDA because it can cause tardive dyskinesia that can be, not always and not most of the time, but can be irreversible even if you stop the medication. So very, very important, if you ever have a patient on this medication, inpatient or outpatient, that you discuss with them the risk of tardive dyskinesia and that you remind them of that risk and make sure that they're comfortable and that they verbalize accepting that risk, and that you document that in your note, because if they ever develop that tardive dyskinesia, you will be on the hook medical legally. So just be very careful of that. But again, no role for that in patients who have primary gastroesophageal reflux disease. Baclofen is another medicine that's been shown to decrease the transient relaxations of the lower esophageal sphincter. It is not FDA approved for the treatment of GERD. The lack of data really played a role in that not gaining approval for that indication. And it does have some side effects. I do not use it in my practice. Some folks do. I have not found it to be helpful. And the guidelines suggest that you don't need to do that. So again, therapy for GERD other than acid suppression and dietary and lifestyle modifications should not be used in GERD patients without diagnostic evaluation to find another condition, for example, like gastroparesis. So let's focus on H2 blockers, H2 receptor antagonists. These are, hold on one second. I'm just going to go back for 1 second. I want to mention two on here. The topical therapies are great for fixing the problem when the acid is in the stomach to neutralize them, but they don't fix the underlying problem. They just fix the acid that's in the esophagus. So that's really not a long-term candidate for treatment. In patients who have mild postprandial reflux, using sodium alginate, Gaviscon Advance is the name of it and the brand name, can be used to sort of form a protective layer at the top of the acid pocket that I mentioned on that hiatal hernia slide. And that can be helpful just for that limited set of patients. And sucralfate or carafate, in terms of a primary treatment for GERD, is not indicated except for in pregnant women. So we don't give carafate suspension for GERD treatment. We can give it for erosive esophagitis and other things, but not as a GERD treatment unless it's a pregnant woman. Okay, now let's focus on the acid blockers. The first of the H2 receptor antagonists. This is famotidine. Of course, ranitidine was there, or Zantac. That's off the market now. I love the fact that Zantac is, the brand Zantac has now come out and said that they're a newly formulated Zantac, and what they are generic famotidine. So Pepcid, Zantac stole Pepcid and now has made it under its own label. So that's kind of funny. They are a little bit faster to act in turning off the acid pumps, but they have a shorter half-life and they are less effective. And I'll show you why in a second. The dosing for mild GERD is generally as needed before taking it an hour before they're going to eat a meal they know will cause heartburn or discomfort, or BID as a preventive means because of the shorter half-life. And the studies have shown superiority of PPIs over H2 blockers in non-erosive disease patients, and we'll talk about that in a little bit. So where do I use H2 blockers? And this is really a nice spot for you in your primary care clinics. Mild GERD, no history of erosive esophagitis or other complications of GERD, symptoms well relieved with H2 blocker therapy, so rare symptoms once a week or less, or very mild symptoms that are occurring and easily completely resolved with H2 blocker use. Those are the ones where you want to use H2 blockers. People who have a history of more severe disease than that, more frequent symptoms, more severe symptoms than that, damage to the esophagus or other organs as a result of reflux, you don't want to downshift them down from PPIs to H2 blockers because of the known severity of their disease. I know everybody likes to get patients off H2 blockers in primary care clinic. Don't do it if the history is more severe than what you see on this slide. So just as this is a super important pearl for you to take, and you'll look like a superstar, although your preceptor will probably disagree with you in clinic when you're in the Ryans, but this is the right answer. Mild GERD, infrequent symptoms, well controlled with an H2 blocker, great, go for it. I'm all in favor of that. More severe, more frequent symptoms, evidence of end organ damage, don't go down below a daily dose PPI, even if their symptoms are gone. Now, why are these PPIs so much more potent than the H2 blockers? I'm going to take you back to physiology and med school, right? This is the parietal cell. Look at the left-hand side of the slide. There are 3 levers that activate the cascade that affects the sodium potassium ATPase on the apical side of the cell that releases the protons into the gastric juices, right? And they are acetylcholine, histamine type 2, and gastrin. If you take an H2 blocker and it turns off only the H2 receptor, the acetylcholine and the gastrin will continue to stimulate the cascade that leads to the proton pumps, putting that acid out into the stomach. So if you use a proton pump inhibitor that affects the final common pathway to those 3 levers, you're going to be much more effective in shutting down acid secretion into the stomach lumen than you will if you only shut down the one lever with the histamine type 2 receptor antagonist. So remember that now as we look forward and look at these old but very important studies. Here's the ability of the different medicines to heal erosive esophagitis. Placebo on the bottom, okay, great. We expect that that's not going to be that great. 1 out of 4 patients. H2 blockers about 60%. PPIs 90 to 95% effective at 3 months out of healing erosive esophagitis. More potent medication, better able to handle more significant disease. This is the one, though, that really drives it home for me. This is long-term esophagitis remission up to a year out, right? Let's start on the bottom. Twice daily ranitidine now would be famotidine, 40 milligrams BID is the equivalent dose, right? Only about 1 in 5 patients maintaining remission from erosive esophagitis at a year. Okay, now go to the top bar, the teal balls and the trend line there. Once a day, PPI, basic dose, 90%, 85, 90% or so, still in remission at a year, right? Now look at the group in the red. These are the weekend warriors. This is you guys when you have your golden weekend and you go out Friday and Saturday night and you do a little bit more than you should, and you probably lie down and go right to sleep as soon as you get back from going out because you're tired and overtired, because that's what residents are, right? And so the erosive esophagitis remission on just Saturday and Sunday morning PPI, the other 5 days of the week not taking it, which obviously is not the correct use of the medication, still had a higher remission rate from esophagitis than taking 14 H2 blocker pills a week. So 2 PPI pills in the week did better than 14 H2 blocker pills, okay, with BID dosing. Just shows you the relative potency. So think about that before you pull back on your medication dosing and when you're thinking about what you do with treating your patients when you see them in the clinic. So lots of PPIs out there. Everything except for Dexalon or dexlansoprazole now is generic, and several of them, as you know, are now over the counter. So we can give empiric PPI therapy for suspected GERD. That is okay. You don't need to do quantitative testing or endoscopy first, unless you have a red flag. What are some of those? Advanced age. Used to be 50. People have moved it a little more towards 55 now. If you have dysphagia or odynophagia, you've got a patient with known iron deficiency anemia who could have internal bleeding, perhaps from erosive esophagitis. Somebody who's got gross hematochezia, right, or hematemesis, obviously, and a failure to respond to a prior trial of acid reduction where you may be barking up the wrong tree. These are folks, or who have more significant disease that they're really going to be dependent on medication. These are folks who need a more in-depth evaluation than just empirically treating them, putting a Band-Aid on whatever is going on and just saying, you're all good, see you later. What about treating other than with medication? Well, anatomic intervention or surgery, either traditional surgery or endoscopic surgery in 2022, there are lots of options that are available. Best patients for this are patients who've had reflux disease well controlled on PPI therapy, but folks who have atypical symptoms, not just heartburn and regurgitation, also relieved with PPIs are also very good candidates. They're less likely to get full relief of their symptoms than the folks who have the traditional typical symptoms, and we have to caution patients of that, but in general, they do very well. If we have esophagitis that's refractory to medical therapy because of the volume of refluxate or the frequency of reflux occurring in the patient, these are good folks for an anatomic intervention to bolster that anti-reflux barrier may be very helpful, right? If someone's a volume regurgitator, if they're bringing up a tremendous amount of fluid, even if you give them 20 Nexium a day and their acid exposure is 0, the bile, the pepsin, the other digestive juices in there may very well be causing the esophagitis, may be causing inflammation up in the throat, may be getting aspirated into the lungs. And so these volume regurgitator patients are folks that we really want to think about performing an anatomic intervention, especially if we've diagnosed a large hiatal hernia. And again, if we do quantitative testing that shows that the amount of reflux that they're having is not controllable with medication, then it's very helpful to consider an anatomic fix in these folks as well. And here's a study now that's been out over 20 years from Lars Lundell over in Europe, showing that whether you give someone a PPI or surgery, they do very well in terms of maintaining remission of their GERD symptoms and erosive esophagitis. And so we actually know that we can use this as a long-term therapy. A lot of gastroenterologists will never refer for surgery. They just don't think about it. They just keep giving pills. You guys in primary care wouldn't necessarily be sending someone, but it's important to recognize that if a patient has consistent and persistent symptoms, despite the therapy that you and or the gastroenterologist are prescribing to them, surgery is a great option. Anatomically fixing the defect that's causing the reflux can be a really good way out of this. And if the gastroenterologist you're working with is not bringing up that option to people, it's important for them to consider that, okay? And I saw the question that just came up about what's the responsible duration to treat after which it's considered lack of response to medical therapy. In patients where I think that someone has reflux, I will give them high-dose BID PPI for 3 months. And if they have not made an improvement on that, at least 2 months, but preferably 3 months, that's when I'll consider them a failure of therapy. But if they've made no improvement at all, I'm starting to doubt my diagnosis, and I'm probably going to take them off medication and do quantitative reflux testing off the medication once and for all to make that diagnosis and say, yes, they really do have reflux and we can't control it, because you don't want to send somebody to surgery without confirming that diagnosis in the first place. Okay, so here's what reflux esophagitis looks like in terms of developing complications. If you have that esophagitis and you don't fix it in a timely manner, what can happen? Well, you can get ulceration. That ulceration can then lead to potentially to hemorrhage or stricture formation, or both, depending on the timeline. And with ongoing exposure, we can get in development of Barrett's esophagus in about 1 out of 7 to 1 out of every 10 patients who have reflux. And since we're going to talk about reflux in a second, someone asked a question about data for Nissen fundoplication versus endoscopic mucosal resection for high volume regurgitators. Well, endoscopic mucosal resection is really a very new technique in terms of being used to treat reflux. Nissen has been around for 60 years plus. There are a number of different responses out there, but I would say right now, endoscopic resection as a means of tightening the valve or tightening the esophagogastric junction is too young to have the data out there. It's really been more some anecdotal stuff and some small case series. And they're often done in patients who are not good candidates for traditional surgery, where doing an endoscopy may be more easily and better tolerated by that patient. So let me keep moving here to talk about the other sequelae. Here's a nice picture of severe erosive esophagitis with ulceration. You can see that you're even getting a narrowing of the esophageal lumen. This person's probably already developing an esophageal stricture, but the earlier you get that patient on a PPI and fix their reflux with all the different interventions you can make, the more likely that tissue will heal and your lumen will open back up without having to do, for example, an esophageal dilation to stretch that area out. And this is the board's question that I always remind on the internal medicine side, super, super helpful. Folks who have a history of reflux and heartburn, regurgitation, that gets replaced by dysphagia. So these are folks who say, yes, for years I had heartburn, I was taking Tums or Rolaids, right? And after a while, yeah, it got better, so I stopped doing that, but I noticed I was starting to have trouble when I would eat steak or chicken. That is a classic story for development of a peptic stricture. And what the body is doing is it's trying to close off the lumen and make a better break wall to reflux so that you restore an anatomic barrier, and the fluids trying to get up from the stomach bounce off against the bottom side of that stricture and go back into the stomach rather than coming up into the esophagus. So remember that history. Heartburn and regurgitation replaced by dysphagia without significant weight loss. Think about a peptic stricture, as erosive esophagitis leading to peptic stricture. So let's finish up the talk with some discussion of Barrett's esophagus. Happens to be a passion of mine and something that I've spent many years doing research and teaching on, because it's such an interesting disease, and one that in the epidemic of reflux that has been taking place in our country, it's leading to a significant growth in the incidence and prevalence of this disease. So what we find in Barrett's esophagus is that the normal stratified squamous epithelium of the tubular esophagus, right, so the biopsies have to come from the esophagus, is replaced by what we call specialized intestinal metaplasia. So it looks like small intestine, and it has goblet cells within the biopsy. So in order to make this diagnosis in the United States, you have to see the salmon-colored mucosa of the columnar epithelium coming up into the tube of the esophagus, and then simultaneously, you've got to be able to find the goblet cell on the biopsy. That is not the case in the UK and in other places where it's just the endoscopic appearance that to them is sufficient. In the US, you still have to make a histologic diagnosis. And this is what it looks like on endoscopy, where you can see, looking down towards the gastroesophageal junction, that the tube of the esophagus has this salmon-colored mucosa working its way distally to proximally up the esophagus and displacing that stratified squamous epithelium, which is that pearly off-white colored tissue that you can see in the foreground. And under the microscope, again, here you can see the villi as well as the goblet cells that are staining with a special stain called Alcyon blue. That's how we make the diagnosis of Barrett's. Okay, hold on one second here. And what are the risk factors for that? Should look very similar to the first part of this talk where we talked about risk factors for GERD. Older age, fat white men. They are like, that's the home run. For us, that's the most likely group to develop Barrett's esophagus, but we certainly see it in plenty of thin, non-white females. It just, the group that is most likely to be found to have this condition are your obese white males. If they've had a long duration of reflux that's been uncontrolled, especially those with an early onset, it takes, we think, 5 to 7 years of uncontrolled reflux to get the Barrett's to form. And again, those with an anatomic defect that predispose to reflux, if reflux is what causes the Barrett's, then things that like a hiatal hernia that predispose to reflux are also predisposing to Barrett's. And what's the prevalence of this disease? Well, it's about 1.6%, which is pretty darn similar to celiac disease. So if you think about it, right, look at all the gluten-free stuff in the Whole Foods. The next time you go in there and all of the trendy gluten-free stuff that you see out there in the internet, about the same number of people have Barrett's, which can kill them, as celiac, which can also kill you, but a lot less commonly than Barrett's can kill you. And we'll talk about why that is the case in a second. But look at that top circle that I made there. 56% of the patients who were randomly endoscoped and found to have Barrett's had reflux-like symptoms on a questionnaire just prior to endoscopy. That means that 44% of patients who were found to have Barrett's did not have any such symptoms and never would have gone for treatment or evaluation or endoscopy if they hadn't been part of this study. Almost half of the patients who developed enough reflux that they now have a precancerous condition due to that reflux didn't know that they didn't have any clue that that was going on in them. And that's why this disease is sometimes known as a silent killer. And in the epidemic of reflux that we're having in the United States and around the world, with obesity creating more and more gastroesophageal reflux disease, we're finding an awful lot more disease, both short and long segments of Barrett's esophagus. And why is this a problem? Well, Barrett's can turn into adenocarcinoma in about 0.3 to 0.5% of patients per year who have just run-of-the-mill regular Barrett's, looks totally normal except that it's specialized intestinal metaplasia in a spot in the body where it's not supposed to occur. But no abnormalities in the cells, no abnormality in the architecture, just intestinal lining with goblet cells in the esophagus. And just as well as seeing a lot more Barrett's, we're seeing an awful lot more cancer. Look at those blue dots that you see here in this graph compared to all the other GI and non-GI cancers, which are sitting in a very nice collective line at the bottom of the chart, where we're doing about the same or perhaps a little bit better over the last few decades of managing this disease compared to the patients who have esophageal cancer, especially esophageal adenocarcinoma. And the thinking is that the Barrett's progresses through accumulation of a series of mutations that come as a result of the caustic injury and probably some genetic predisposition, which is why we think there's a familial connection to this disease as well, accumulating more and more mutations until we go from metaplastic disease to dysplasia and then ultimately to neoplasia and carcinoma. And you can see under the microscope that those changes are easier and easier to see the higher and higher degree of abnormality that there is histologically. And as I said, about 0.3 to 0.5% per year progression from non-dysplastic Barrett's to cancer, although probably in a US population closer to the 0.5% range, in part because of our diet, in part because of our body mass index on average as a country. But also, the fact is that a lot of our folks are not as able to access care or are less willing to access care in a preventive capacity to keep them from developing out of control reflux that then leads to the formation of this disease. And then once you've got dysplasia, the horse is out of the barn, and that dysplasia progresses to cancer even faster. And that's why when we find dysplasia on a surveillance program, which is what we put all of our folks with diagnosed non-dysplastic Barrett's into, that the survival curves are better because we're able to head off the disease and intervene even before the cancer forms now, which was not the case back in 1998 when this study came out. So we're even better now than we were at that time. We know that PPIs can blunt the development of dysplasia within the Barrett's. So we always have our patients on Barrett's who have Barrett's esophagus who can tolerate PPIs. We put them on PPI therapy. And we have lots now of endoscopic treatments, from radiofrequency ablation of the disease, cryotherapy to freeze off the disease, endoscopic resection to resect or scoop out the disease, endoscopically as an outpatient to get rid of this disease so it never becomes a cancer, or esophagectomy if the cancer forms. Photodynamic therapy and other therapy that's out there that's used minimally used to be in favor before RFA and cryotherapy became really well tolerated and very efficacious options, sort of pushing PDT to the bottom of the list. So let me stop there. I know we're getting close to the end time for the hour. Thanks so much for your attention. I hope you found this interesting and helpful for some of your patients in clinic and in the hospital. And I thank you for coming, and let me take any other questions that are out there.
Thank you so much, Dr. Smith. So yes, if you have any questions, anyone, feel free to write it on the chat or unmute yourselves right now.
Can I comment on laryngopharyngeal reflux and how it differs from GERD? Do we have another hour? Oh, hold on one second. Let me answer this question, and I promise I'll take yours. So laryngopharyngeal reflux is something that the ENTs will diagnose an awful lot and will send to us. And as I remind all my patients, you can't have laryngopharyngeal reflux if you don't have gastroesophageal reflux to put the fluid into the esophagus to begin with. So if we're talking about disease of gastric contents causing damage in the throat, it has to get into the esophagus first. So the way that I always manage those patients is I evaluate them for gastroesophageal reflux. And if they don't have it, I tell them they can't have laryngopharyngeal reflux of esophageal contents of gastric contents because they never got into the right organ to begin with. And so evaluating folks for laryngopharyngeal reflux to me starts with a GERD evaluation, and their management is similar, except that we know that patients with atypical symptoms of reflux, and that's sore throat, chronic cough, voice change, often take BID dosing of their PPI and a longer duration of therapy, up to 3 months, to see symptomatic improvement. So in those folks, I remind them that their heartburn, if they have heartburn and regurgitation, that may get better in a week or two. But they can't just give up after 14 days and say, I failed therapy, if they have atypical symptoms that we haven't yet given a full duration of treatment with the higher dose PPI therapy. So that answers that. I know somebody was speaking. Let me take the spoken question next.
So yes, I was wondering about the H2 blockers. So why not just give PPI for everyone? Do you want to say those if you would need to escalate, or?
So there are two, that's a great question. There are two approaches, right? Some people will step up their therapy and start everybody on an H2 blocker, see how they do, and then go to a PPI. And some people will do top down. They'll give everybody a PPI, and if they respond really well, they'll try and de-escalate to an H2 blocker. I'm more of a top down than a step up, but to be honest with you, it goes back to the history taken that I was telling you about when we were looking at the guidelines. If they just have a couple of times a month some mild GERD symptoms that are well controlled with acid blockers, I will try them on an H2 blocker first, or even either standing or again as needed if they know what their trigger foods are. They say, I go out for margaritas on Taco Tuesday a couple times a month with my friends, and that's when I get heartburn. You know what? Take a famotidine, 40 milligrams an hour before you go out. You'll probably be okay, right? If somebody has more than once a week of symptoms or more severe symptoms, I'm not going to put them on an H2 blocker to begin with, because I know that the data suggests their disease is too severe for that. So that's a great question. Again, it goes back to that history. Frequency and severity of symptoms and evidence of end organ damage are going to help you to figure out what the optimal first approach is from a medication standpoint. Okay. Let me go to the H. pylori, any rule to rule out H. pylori before starting PPI for GERD, especially with dyspepsia. So I love that idea. You have to be doing H2 blockers. You have to be off H2 blockers and PPIs and any acid blockers really for 14 days before you do a breath test for H. pylori. So if you haven't started someone and they do have dyspepsia, great idea to either get an H. pylori stool antigen or an H. pylori urea breath test. That's in another lecture we can go into. But doing that testing off is great. You can check for H. pylori on PPI if you do an endoscopy with gastric biopsy. So that's something else to consider. But again, if your symptoms are pushing you more to epigastrium, think about dyspepsia before you go down the reflux route, unless they have both GERD symptoms and dyspepsia. And in that case, think about a functional disorder that may be affecting both of the organs in the foregut, the stomach and the esophagus. Probably running out of time. Yes, true, Dr. Seward's calling me to a meeting, but you guys are more important, all right? And next time he asks, you tell Dr. Andrilli I said that, okay? If we do have some time at the end, any literature on TCAs and SSRIs to treat GERD regarding as a form of dysmotility. So not to treat GERD, but to treat the visceral hypersensitivity component if the esophagus is oversensing what's going on in the setting of GERD. Dr. Shenoy has become an expert in this, working with me in the last week. She's seen a ton of this stuff. But the fact is, in patients where a normal amount of reflux is causing all those symptoms, where your acid exposure is normal, a PPI is probably not going to do much unless the symptoms that they're having are well-timed and correlate well with the reflux events. You can use a tricyclic, an SSRI, SNRI. You can use gabapentin or pregabalin. You can use trazodone. These are all in the family of medications called neuromodulators, as you know, that all can sort of turn down the volume knob and the sensitivity and break the cycle of the body ramping up every time it feels a reflux event that it thinks is going to kill you with asphyxiation, right? And so, yes, absolutely part of it, but if they have clinically significant reflux on quantitative testing, we always give therapy for the reflux. And then if they fail that therapy, but they're quantitatively now normal, then we can think about doing a tricyclic in combination with them. But we saw a patient earlier today who had a very normal amount of reflux, but good symptom correlation, and we put them on a tricyclic because the amount of reflux they're having is normal. They're just over-sensing how much that's changing their body. And so we're using the tricyclic to break the cycle of over-sensation, visceral hypersensitivity, and that should do the trick without having to put them on a medicine that they don't need because their acid exposure is totally normal. And they had zero symptom correlation between them.
Okay. Thank you so much, Dr. Smith, for all the detailed answers, the great lectures, and we will pass a message along to Dr. Andrilli about what you said. So
don't replay this for Dr. Seward, all right?
Okay. So thank you, everyone. I see Dr.